In this session, we are going to look at the treatment of heart failure. In the previous video, we have looked at the causes, signs, and symptoms. We have looked at the categories, which we had systolic heart failure and diastolic heart failure, whereby under systolic, we saw it was due to reduced ejection fraction. Then under diastolic, it has normal ejection fraction. And we saw different compensatory mechanisms, whereby when there is heart failure, the body adapts by increasing sympathetic nerve system activity, increasing RAAS activity, and also causing myocardial hypertrophy. So in this session, we are looking at the drugs which target either by decreasing those compensatory mechanisms or by looking at how we can treat this heart failure. So as we begin, we urge you to subscribe if it is your first time, like the video. This is how you can support us so that we can grow. Let us get started. So different categories of drugs are used in the treatment of heart failure, and the first category we are going to look at is renin-angiotensin aldosterone system inhibitors. And these drugs, for them, they act, as we saw that when there is heart failure due to reduced cardiac output, it is going to cause what we call that decreased cardiac output leads to decreased perfusion to the kidney, which leads to production of renin. And this renin, due to decreased perfusion or due to action of beta-1 receptor, is going to convert a protein from the liver called angiotensinogen to angiotensin 1. And this angiotensin 1 is converted to angiotensin 2 by the enzyme from the lungs called angiotensin converting enzyme. Then we saw that this angiotensin 2 has different receptors in the adrenal cortex, receptors in the blood vessels, that is veins and artery, then also in the hypothalamus. This one stimulating production of ADH, this one causing vasoconstriction, then this one leading to production of aldosterone hormone. So in this category of RAAS inhibitors, we are going to see drugs which inhibit the angiotensin conversion of angiotensin 1 to angiotensin 2. We are going to see drugs which inhibit the receptors of the angiotensin 2, and the drugs which compete with aldosterone. So we are seeing category 1 is ACE inhibitors. Then we shall see category 2, which is ARBs, angiotensin receptor blockers. Then we shall also look at aldosterone antagonists. So these are the three categories. This aldosterone category, you can call it potassium sparing drugs. So these are the three categories we are looking at, the RAAS inhibitors. These ones aim at decreasing either activity of angiotensin 2 by blocking either its formation or its action on its receptors, or also inhibiting aldosterone purpose. So these ACEs, as we have seen, their mechanism of action is by blocking the conversion of angiotensin 1 to angiotensin 2 by directly inhibiting the action of angiotensin converting enzyme. So after doing this, examples of these drugs include, they end with pril, whereby we have drugs like captopril, enalapril, lisinopril, then fosinopril. So all drugs that end with pril, These ones belong to ACE inhibitors. And these drugs, they are being used for treatment of heart failure, especially they majorly target both systemic and diastolic heart failure, including ARBs. ARBs examples include, they end with Saturn, whereby we have losartan, then we have condensartan, valsartan. All these are drugs we can use also in treatment of both systolic and diastolic heart failure. Then aldosterone antagonist or potassium sparing. An example here, we can look at drugs like spironolactone. Then we have also epirolone. Is also another drug we can use. So these two drugs, they are potassium sparing, but they competitively, they compete with aldosterone on their receptors in the distal convoluted tuber of the kidney. So we don't see, when we use them, these ones inhibit sodium reabsorption. They inhibit sodium reabsorption, hence also decreasing water reabsorption. So these ones, for them, they majorly work on solving the issue of edema, because edema due to increased blood volume. So when there is increased blood volume due to much reabsorption of sodium, and maybe the patient is not responding on ACIs and ARBs, we can easily use potassium sparing. Also, in patients with hypokalemia, because one of the side effects or ADR of these drugs, ACEs and ARBs, is causing hypokalemia by increased also loss of potassium. So in case of hypokalemia, we can also opt for aldosterone antagonist, which we are calling potassium sparing, and a peculiar example is spironolactone. So these are the drugs we can use. We have seen their indication is for treatment of both systolic heart failure, that is due to reduced ejection fraction, together with also treatment of diastolic or reduced ventricular filling. We can use all these drugs. And how do they act? After inhibiting these processes, if I inhibit formation of angiotensin II, meaning there is no going to be production of aldosterone, which will result into increased sodium excretion and water, hence reducing the blood volume. It will act on the blood vessels. There will be no action on the blood vessels, so it will cause vasodilatation. Then there will be no production of ADH, so no water is reabsorbed. So these all will increase both afterload and preload, because this dilatation decreases preload, decreases afterload. This one will decrease afterload, then decreased. If I block aldosterone and I block production of ADH, little sodium is reabsorbed and little water is also reabsorbed, meaning I'm excreting much of the sodium in urine, so which will result into reduced preload. So preload will also be reduced. So there is produced afterload and reduced preload. And all these ones can result into solving our problem of heart failure. If I decrease afterload, the heart can be able, the ventricles can be able to pump blood. Then if I reduce preload, I'm reducing the activity of the heart. Hence, I can be able to solve the problem of heart failure. Their contraindication, these ones are contraindicated in pregnancy, because they are teratogenic, contraindicated in pregnancy. That is what we can see. And some of the side effects is gout due to increased uric acid reabsorption. So we can see gout or hyperuricemia with this, and sometimes gynecomastia. But I want you to note that they are contraindicated in pregnancy. That is what we can talk about this. Then another class under RAAS is that if someone is failing on these drugs, we can combine these drugs, say, for example, ARB, together with neprilysin inhibitors. So this is another combination whereby you give an angiotensin receptor blocker together with neprilysin inhibitor. This neprilysin, its work is to degrade. It is used to degrade atrionatriuretic peptide. It can degrade BNP into its inactive metabolite. So if I inhibit neprilysin enzyme, I increase levels of these vasoactive substances, that is ANP and BNP. So ANP and BNP, they are responsible for increasing sodium stroke water excretion. They are also responsible for relaxation of both the myocardium and the blood vessels. So this drug, we can use it together with varusatan. So it is always varusatan, which is an ARB, combined with sacubitril, which is a neprilysin inhibitor. So this combination is very good for those which are failing to comply with SCEs and ARBs alone, that we can achieve maximum therapeutic use by combining ARBs together with neprilysin inhibitors. So this is also very important in treatment of heart failure. So this is one category we have finished, those are RAAS inhibitors. Then the second category of drugs we want to talk about in this session is diuretics. You can also use diuretics, and the commonly used diuretics is ROOP diuretics, the one which are commonly used, or sometimes so majorly ROOP diuretics, then at a smaller extent thiazides can be used, but majorly ROOP diuretics are preferred in treatment of heart failure, especially heart failure accompanied with edema, both peripheral and pulmonary edema. So if there is edema, patient who has heart failure with peripheral or pulmonary edema characterized by shortness of breath, which we call dyspnea, and swelling of the lower limbs, you can treat them by giving them first diuretics. And under ROOP diuretics, which are preferred, is furosemide. You can give furosemide. You can give torsemide. You can give bumetanide. Bumetanide is also a ROOP diuretic. So this is the preferred in treatment of heart failure with edema, both peripheral or pulmonary edema. You can the first line treatment is the ROOP diuretics, which sometimes you can easily combine with them with hydrochlorothiazide. Hydrochlorothiazide, which is a thiazide diuretic, but preferred is furosemide, torsemide, and bumetanide in the treatment of fluid retention in heart failure. So that is what we can talk about under ROOP diuretics. And remember also, ROOP diuretics are contraindicated in pregnancy and people with hypokalemia. If there is hypokalemia always combine them with the potassium-sparing diuretics. That is what we can mention under this class. Then the third class we can talk about in this session is we can look at the vaso and venodilators. So vaso and venodilators are also the drugs of choice we can use in treatment of heart failure. And how is it done? That these drugs, they target the arteries. The vasodilators, they target the artery, they cause arterial dilatation, whereas the venodilators, they lead to the dilatation of veins. So if I give a vasodilator, dilatation of the artery leads to decrease in systemic vascular resistance, which leads to decrease in afterload. So afterload decreases. Whereas if I cause venodilation, this one I increase preload. When they dilate, I actually decrease preload. There is preload reduction due to decreased venous return. So these drugs are very essential in the treatment of both systemic and diastolic heart failure. In case they have been resistant on SCEs, ARBs, and diuretics, you can also switch to vaso and venodilators. And examples of the vasodilator here, the drug we use for relaxation of the arteries is hydralazine. Hydralazine is preferred, though because of its action, it is always required to monitor patients with BP because it can lead to hypotension when given in a faster. So it should be given as a slow release IV because of its tendency to cause hypotension. Then the venodilator we can use is isotretinoin dinitrate. So these are nitrates. So isotretinoin dinitrate can also be used as a venodilator. And when it causes the venodilatation, it decreases the preload, which decreases the requirement of the heart to contract so much, which can treat heart failure. So we are seeing this one is targeting treatment of heart failure with reduced ejection fraction. Then this one treats heart failure with normal ejection fraction. This is diastolic, this is systolic. So if we give them in combination, we can be able to treat both types of heart failure. That is the vaso and the venodilators. Because this one decreases afterload, this one decreases preload. Hence we can relieve the tension of the heart, hence resulting into treatment of the heart failure. Then category number 4, we can talk about the positive inotropes. Positive inotropes. The positive inotropes, these ones, they act by increasing contractility. They increase contractility of the heart. And it is categorized into 3. We are going to have the positive inotropes, which we have the sympathomimetics. Sympathomimetics, those are the beta agonists. And an example here, we are going to look at dobutamine. Is the one which is commonly used, though all these types, they decrease mortality, whereas sympathomimetic like dobutamine increases mortality. So it is less commonly used due to its side effect of increasing mortality. That is the beta agonist, which we can call dobutamine. Then another class we are going to talk about under this positive inotropes, we have Diuretics, or what we call cardiac glycoside. And the cardiac glycosides, the big example here we shall use is digoxin. Digoxin is preferred to digitoxin. So that's why we are going to look at digoxin, which is the Diuretics. Then another inotrope we are going to talk about under positive inotropes is, there are three categories. Another category we're going to look at is phosphodiesterase. Phosphodiesterase inhibitors. So these are the two categories under positive inotropes. And all these, they act, if this is my cardiac cell, these ones have what we call sodium stroke potassium ATPase channel. There is also another channel responsible for sodium stroke calcium exchanger. So what happens in the cardiac is that these positive inotropes, in the normal situation, we see sodium being pumped out of the cell as potassium enters. So sodium is pumped out and potassium enters into the cell. And when this happens, it decreases the levels of sodium in the cell, which leads to more influx of sodium via sodium stroke calcium exchanger. And it happens in exchange with calcium. So calcium moves out as sodium comes in. So what happens if I use a drug like a beta agonist? This is a beta agonist. It is going to block a beta agonist, or especially the digoxin. Digoxin acts by blocking sodium stroke potassium ATPase pump. And when blocked, it increases intracellular sodium ions, meaning the sodium stroke calcium exchanger will not bring in more sodium because there is much sodium inside. And when there is no sodium coming in, calcium does not exchange. So this one leads to increase in intracellular calcium levels. And increase in intracellular calcium levels leads to contractility of the cardiac. So this is how digoxin acts by increasing, by blocking sodium stroke potassium ATPase pump, and this one leads to increase in intracellular calcium ions, leading to contractions. So that's why we said digoxin increases contractility. It does not decrease mortality, hence does it cause mortality. So for it is a flat, and it is commonly used when patients have failed to respond with the diuretics and the RAAS, or it is given in severe. So this digoxin is good in treatment of severe heart failure, especially characterized with edema. So if there is edema, you begin with a diuretic, and then after diuretics, you can give digoxin as a drug of choice in treating this severe heart failure. Then what do phosphodiesterase inhibitors do? Another action is that this dobutamine, which is the beta agonist, acts by increasing CAMP in the cell. And when CAMP levels increase, they cause activation of protein kinase which go and phosphorylate the channels or the receptors for the calcium, leading to release of calcium channels, increase in calcium. The same thing, so what happens is that this one leads to increase in calcium levels, which leads to contraction. This is leading to increase in the contractility. But with phosphodiesterase inhibitors, we know that when the CAMP increases, if you have increased CAMP levels in the cell or the cardiac vessel, it is degraded. This CAMP is degraded to AMP, that is adenosine monophosphate. And it is by this phosphodiesterase enzyme that breaks down or that degrades this CAMP, leading to decrease in the CAMP levels. So what phosphodiesterase inhibitors do, they block the phosphodiesterase enzyme, which is responsible for degrading CAMP to cyclic AMP. So when we stop the breakdown or the degradation, CAMP levels increase. So when we increase CAMP levels, we activate protein kinase type A, which go and phosphorylate the channels of calcium, leading to increase in calcium levels, hence resulting into contraction. So that's why we are saying that all these types act by increasing contractility of the heart. So they are best indicated in patients with heart failure with reduced ejection fraction, though we have seen drugs like dobutamine can cause increased mortality in patients. And we have said digoxin is only and only used in severe heart failure. Following, if there is problems of shortness of breath, edema, paroxysmal dyspnea, you can easily first give the diuretic like furosemide, tosemide, then followed by digoxin. So that is what we can see under this positive inotropes, which act by increasing heart contractility. These ones are not used to treat diastolic heart failure, majorly systolic heart failure by increasing contractions of the heart. That is what we can talk about this category number 4. After talking about category number 4, that is beta agonist dobutamine, don't forget about it. Used in treatment of, especially this dobutamine can be used in treatment of acute congestive heart failure. Acute congestive heart failure. Then we have seen digoxin, severe heart failure, or what we can call severe congestive heart failure. Then this PDE can also be used in the treatment of systolic heart failure. And another thing we can talk about digoxin, we can also use to treat patients with heart failure together with atrial fibrillations. Though the major side effect can lead to cardiac arrhythmias, but we can treat heart failure with atrial fibrillation using digoxin together with severe heart failure. That is what I wanted you also to note on these drugs that increase heart contractility. The number 5 category we are going to look at in this session is the beta blockers. Going to talk about the beta blockers. Where beta blockers so these are sympatholytics, the beta blockers. And this is another category number 5 we are looking at in this session. The adrenergic blockers or the beta blockers we saw by compensation. When there is a decrease in the cardiac output, there is a stimulation of cardiovascular center in the adrenal medulla, in the medulla oblongata. which leads to increased production of norepinephrine neurotransmitter. And increase in production of norepinephrine, this one goes to the cardiac muscles, that is the heart, where there is beta-1 receptors, and it goes also to the juxtaglomerular cells of the kidney, and also goes to the alpha-1 receptors in the blood vessels. So what happens with this? If we stimulate this, it increases the contractility and conduction. This one leads to production of renin, and this one leads to vasoconstriction. So what happens? If I use a beta blocker, these beta blockers come and block the receptors within the heart, that is both the sun and the myocardium. They block the beta-1 receptors in the kidney, then they block also alpha-1 receptors in the blood vessels. Those ones which are beta-1 selective include, here we shall include examples. Examples here that block only beta-1 is bisoprol, and metoprolol. Metoprolol succinate or succinate. So these ones, they are cardioselective or beta-1 selective blockers. Whereas the one which is non-selective, which blocks both beta and alpha, this one is non-selective, is carvedilol. So carvedilol is non-selective and is preferred in the treatment of heart failure, especially these drugs are indicated in the treatment of chronic artery disease, which can lead to heart failure. We can also use it in treatment of systolic or heart failure with reduced ejection fraction. Then we can also use it in the treatment of immediate or what we can call post-myocardial infarction, or someone after having a myocardial infarction, what we can call heart attack. So these drugs can be used. But carvedilol is preferred because of its action on both beta receptors and alpha receptors. So carvedilol, for it has ability to decrease. If it blocks the beta receptors, it is able to decrease afterload. At the same time, in the alpha, it is going to cause vasodilatation due to blockage of alpha-1 receptors, also leading to decrease in preload. So this one can be used to treat both diastolic and systolic, which is different from bisoprolol and metoprolol succinate, which can treat only systolic heart failure. So carvedilol is preferred on this in the case of patients with both historic and diastolic. And some of the adverse reactions or contraindications, it can, the adverse reactions, that is ADRs, we can see bronchospasms. In the case of someone with asthma or chronic obstructive pulmonary disease, these drugs like carvedilol is contraindicated because we have alpha-1 receptors within the bronchiole, within the bronchus. So in the case of asthmatic patient or COPD patient, carvedilol is contraindicated because they can lead to bronchospasms. But still we have also another effect of this drug is that they can cause hypoglycemia. They can lead to decreased blood sugar levels. That is what we can talk about under beta blockers. Don't forget bisoprolol, metoprolol succinate, and carvedilol, whereby metoprolol and bisoprolol, they are cardioselective, whereas carvedilol is non-selective. It acts both on the beta-1 and the alpha in the blood vessels. So the last category we are going to look at in this session is the drug which can decrease both contractility and conduction. And this drug is named as is named as, this is the drug, Ivabradine. This drug, for it acts by decreasing contractility of the heart, decreases contractility. At the same time, it decreases conduction. And when a drug, such a drug decreases both conduction and contractility, it means it is going to delay depolarization. And as depolarization is prolonged, it does not delay, it prolongs. So this one leads to prolonged repolarization. So prolonged repolarization will result into increased ventricular filling, meaning this drug can be used to treat both systolic and diastolic. Systolic by increasing contraction, which increases ejection fraction, and by decreasing conduction. And when we decrease conduction, it increases ventricular filling. Hence, we can use it also for treatment of diastolic heart failure. Because if we increase filling, we are able to improve on cardiac output. So this is Ivabradine, which can be used to decrease both contractility and conduction of cardiac impulses. So these are the categories of the drugs we can use, we can see under treatment of heart failure. We have seen RAAS inhibitors, which included ACEs, ARBs. Then we had aldosterone antagonist together with ARB in combination with a neprilysin inhibitor, used and first choice in treatment of both systemic and diastolic heart failure. Then the second was diuretics, especially the loop diuretics, which decrease both afterload and preload. And when it happens, we saw that they can be used in treatment of pulmonary and peripheral edema. So that is the ones of choice. In the case of extravasation, there is leakage of plasma into the interstitium, characterized by edema. You can use diuretics like furosemide, etosemide, and bumetanide, and sometimes you can combine them with hydrochlorothiazide. But commonly used is the loop diuretics. And their mechanism of action is that they act by blocking the reabsorption of sodium stroke potassium stroke 2 chloride at pace pump. Then the vasodilators and the venodilators, treating both reduced heart failure with reduced ejection and preferred ejection, which is normal. Because an example is hydralazine and isotide dinitrates, which can be used both on the arteries, decreasing afterload, then on the vein, decreasing preload. Then positive inotropes, we have seen their major action is increasing calcium. And when we increase calcium, we increase the contractility. And these ones have shown, especially the beta agonist, the butamine, which can increase mortality in heart failure. So it is not preferred, but we can use it for a short term in the treatment of acute congestive heart failure. Then the digoxin only used in severe heart failure, and also patients with heart failure together with atrial fibrillations, because it blocks the sodium stroke potassium at pace. Then PD inhibitors, we have also seen them, which increases CAMP levels by inhibiting phosphodiesterase enzyme. Then last year we have looked at the beta blockers and the Ivabradine. Beta blockers containing bisoprolol, metoprolol, succinate, together with carvedilol, whereby carvedilol increases both afterload and preload. And in so doing, by decreasing both afterload and preload, can be used in treatment of both with reduced ejection and those with normal ejection fraction. Whereas bisoprolol and metoprolol succinate is only for systolic heart failure, together with the coronary artery disease and post-myocardial infarction. So this is what we can discuss with you in this session. Thank you so much for always learning with us at Medical Sciences. Please never always forget, always remember to subscribe, like the video, then share it to many others so that we can continue to teach the group.